It is 4:45 on a Friday afternoon. In a few minutes, a patient will walk into this clinic. For someone experiencing their first episode of psychosis, the clinical decisions made in these rooms set a trajectory for years. Early intervention in psychosis, or EIP, is a fragile window where the right support secures recovery, while a misstep leads to permanent isolation. But the practitioners trying to provide this care operate in fragmented pods, separated from primary care, disconnected from social services, and divided by separate budgets. A clinician sits down to deliver holistic, evidence-based therapy, but instead finds themselves navigating administrative noise, prescription requests, and disjointed IT systems. This guidance document outlines the standard characteristics of an EIP service. As highlighted in this bulleted list, effective care requires small patient-to-staff ratios. However, systemic overload makes following these basic guidelines nearly impossible. One clinician cannot hold the weight of an entire fractured psychiatric system for the human being sitting right in front of them. EIP sits at the intersection where systemic bureaucracy, public risk, and human fragility collide. Without structural help, this operational model remains unsustainable. Stepping outside that single clinic room, we see the broader, invisible forces acting on the patient. Researchers at University College London, pictured here, are currently leading the Odd-Deci trial to test an approach known as open dialogue. This model suggests that treating severe mental illness requires bringing families and social networks into the care process from the very beginning. The relationships themselves become a crucial part of the clinical outcome. The clinical picture is further complicated by cultural context. This report from the Advisory Council on the Misuse of Drugs reviews how factors like structural racism and stigma influence both the reporting of drug use and the subsequent treatment. This data breaks down those disparities. While past-year drug use is highest among white populations at 26%, the dependency rates tell a different story. Adults in the mixed ethnic category record the highest rate of dependency at 22%, compared to 15% for white respondents and 6.4% for Black respondents. These numbers show that medication and therapy must be delivered with cultural humility. A patient's mistrust of services or fear of community ostracism directly impacts whether they accept help. Attempting to treat psychosis without mapping the patient's specific cultural reality and social network reduces a human being to a pharmacological data point. We also have to consider the gravity of public safety. This page from the investigation into the Nottingham tragedy details the urgent need to improve how risk is recognized and managed across care settings. When care is fragmented into isolated pods, critical information falls through the cracks. This leads to communication failures between community mental health teams and primary care physicians. This investigation outlines how non-engagement with EIP has become a normalized reason for discharging high-risk patients, as clinicians make rapid decisions on overloaded schedules. This lack of communication means agencies shift blame when a case goes wrong. A gap exists between the controlled world of clinical trials and the messy reality of community mental health. This guidance document points out the specific risks of the hub-and-spoke care model. Implementing evidence-based treatments is difficult when EIP workers are left isolated, lacking clinical supervision, and facing abrupt increases in caseloads. Risk management collapses when the system lacks the structural pathways to execute clinical knowledge safely. We return to the clinician at the desk, physically overwhelmed by the convergence of risk assessments, cultural data, and evidence-based guidelines swirling together. This appendix summarizes dozens of factors influential to service implementation, from funding deficits to physical infrastructure. To navigate this, we need technological systems capable of mapping these variables. Integrated digital systems function as a narrative organizer, fetching evidence-based guidelines and mapping them against a patient's social network in real time. Fetching research and risk data bridges the gaps between isolated pods, organizing chaotic information into a coherent map. Shifting the tracking of these variables to a digital system returns the mental capacity needed for human connection. The technology itself should fade into the background. The goal is to allow the clinician time to sit quietly and listen to the patient. Human lives are inherently complex. Early intervention doesn't need to flatten that complexity into artificial checkboxes. It needs a system strong enough to hold it. In the end, many streams, one purpose.